Not yet, hold on. We are great. Hi, everyone. Welcome back to the afternoon session on Thursday for healthcare. And we're still talking about H766 and act relating to prior auths, therapy, insurance claims, provider contracts, and collection of cost sharing amounts. And today we're talking about section 2, which is the claims edits. So Jordan, welcome back this afternoon. Hopefully you had a nice lunch.
A quick one, but a nice one.
Good. So if you can introduce yourself again for the record and then start your testimony.
Sure. Good afternoon for the record. Jordan Esty, Senior Director of Government Affairs with MVP Healthcare. Appreciate the opportunity to join you again and talk about the claims edit sections of H766. So generally on these proposals, we're generally supportive. You know, we have no issues with, I think, what you're trying to accomplish here, which is standardization and alignment, clear expectations around notification and the communication of any updates we make as part of our payment policies. That is all, that is all fair and something we could support and be comfortable with. As a practical matter, I have not been able to identify any scenario where MVP is auditing for claims validation edits across the board before we pay a claim. But we do reserve the right to do so retrospectively on audit, and I think I had shared that in writing last week as part of comments when this was first discussed. Our payment policy updates are largely in line with CMS and other national industry standard approaches, and in line with any new regulatory requirements that happen, throughout the course of a year. We largely make those changes on a quarterly basis. We don't have strong concerns with making those edits only once a year as proposed in the bill, but worry that might be a significant challenge for smaller providers to operationalize everything at once. So just want to flag that. I do want to flag two specific concerns. One is on page 6, line 12. The language is drafted would prohibit health plans from using any prepayment review for any claim. I think our concern is this is very broad and it would sweep in scenarios where we might look at certain claims or certain providers before rendering payment. So to be clear, as I mentioned earlier, we do not establish blanket prepayment review requirements on all providers or on all claims with a specific modifier, for example, but prepayment review is a really important tool for the plans. The most obvious example is around potential fraud or abuse. We also look at really expensive claims to ensure that all of the information and documentation is there before we pay the claim. And there are also times where we may have a provider that has persistent billing issues where we might say to them, hey, we're going to put you on some sort of temporary prepay review and work with you to resolve the issues that you're having. I think related to that point, it's important to remember that there are member impacts here too. So we talked this morning about out-of-pocket cost shares. And what we don't want is members to be overpaying for services because of claim submission issues, right? As complicated as collecting cost share might be today, it becomes even more complicated if the member is now involved and we're having to correct claims and issue refunds as part of the whole process. So we do have concerns again with that provision on page 6 that it seems like a blanket statement that we would be prohibited from using prepayment review on any claim or with any provider for any situation. So we would ask you to consider narrowing that. Two, I just want to raise a second concern regarding sections 5 and 6. And really, this is a question about legislative intent.
So I'm sorry, 5 and 6.
5 and 6 concerning contract amendments as it relates to edit changes and things of that nature.
Okay.
So if the intent of this language is to require two-party acknowledgement or signature anytime a payment policy update is made, and typically today we'll make the changes and provide 90 days advance notice before those take effect. But we that is part of the contract that will provide advance notice information, but we don't go through kind of the typical two-party negotiation on the contract itself. So if the intent there is to require us to get kind of that two-party signature anytime any update is made, the administrative lift of that and the cost associated would be significant. We have thousands of providers we contract with, and that would just be really significant cost issue that would ultimately be borne by our members in the form of higher premiums. So maybe that's not the intent, but I just raised that for further discussion.
Okay, so Jordan, I'm sorry, can you direct me to a page?
Yes.
Okay, sorry. So you're like real section 5 and 6. Okay.
The section 5 starts at the bottom of page 12.
Got it. The fair state contract standards and then the contract
Yeah, and
amendment.
specifically, if you go to page 14, subsection 5, if we use any policies or manuals to augment the content of the contract, the entity shall ensure those providers contain sufficient information to allow providers to understand and comply with the content. That's fair. The contracting entity shall treat any new policy or manual and any change to an existing policy or manual as a contract amendment. And shall
Okay.
comply with the requirements for contract amendments set forth in section 94(1)(d) of this title. And then section 6 is, for purposes of this section, a contract is deemed to be amended when an entity institutes a new policy or manual or amends a new policy or manual that is incorporated into contract by reference, and the new or amended policy or manual impacts the healthcare provider's reimbursement. So again, I just want to flag that for further discussion about intent here is the intent that we have to go through kind of the formal contractual two-party review and signature anytime a change is made. That would just be administratively complex and costly.
Thanks, Jordan. I don't think that is the intent. So we'll work with you on potential new language in that.
Okay. And that really is the bulk of our comments on these changes, but happy to answer any questions here or offline.
Okay. We have Alyssa.
So as you were saying it, I should have caught this in the bill. I mean, I read the bill 1,000 times. The ability to change your claims edits only once a year. Are we inadvertently precluding you from adding codes once a year? Because I'm just thinking back with the endless series of COVID injection codes that kept getting added like every 2 weeks.
Yeah.
Are we basically saying you can't add new codes? And if we are, can you suggest language to us that we can get around that? Because that is not our intent in any way.
Yeah, that's a great question. Something that somebody asked internally, and I assumed that wasn't the intent, but COVID was kind of the example, probably the most extreme example that was referenced, that there are new codes emerging weekly,
Kind
of what the the cadence was. But to that point, we wouldn't want to unintentionally limit our ability to do that. And I'm happy to talk with my peers and other stakeholders around ensuring that's not unintentionally captured here.
Okay. That is not our intent at all, and I want to make sure that we're not doing that.
I have questions for Jordan. Great. Thank you, Jordan. We will we'll hear from Sarah and we'll have some committee discussion. You're free to stay or not, obviously, but we'll be back in touch about our next steps.
I'll be listening in the background. Thank you.
Okay, great. Thanks. Sarah?
Thank you. Sarah Teachout, Director of Government and Media Relations for Blue Cross and Blue Shield of Vermont. And I think I did provide you all with a letter and attempted to answer your questions. And I think I wanted to start out the discussion by acknowledging that the changes that Blue Cross and Blue Shield of Vermont made to our claims editing system were poorly implemented and had a fairly harmful impact to providers. So, I wanted to start out by acknowledging and apologizing for that because it has been an uncomfortable place to be, I think, for all of us.
Thank you.
As far as the language in the bill, I have many similar comments to Jordan and a couple additional. So the parts, I'll just pull them up. And I have spoken to the sort of group of providers that we've been working with. I don't think there's any agreement, so I'll just throw out what I've been advocating for so you know what my concerns are. On section 2, it's the sort of the middle of page 5, and it limits the claims edit rules that we can use when applying edits only to NCCI codes.
Can you say what NCCI is first?
It's the National, oh, I'm lucky it says it above, the National Correct Coding Initiative, I think. Did I get that right? Yeah, thank you.
Medicare, or is it just some? Yeah, okay.
You can get behind my knowledge here pretty quickly, sorry.
That's fine, keep going.
So when I talk, so I think most of this is focused on the medical claims that providers have been doing, but there also are some implications for our pharmacy claims. Because we apply claims edits on there too. When I was speaking to our director of pharmacy, she says that we use Metaspan, the National Pharmacy Database, and also clinical edits such as concurrent drug utilization review and retrospective, which maybe wouldn't apply here, drug utilization review. So there are some, she said Metaspan, First Data Bank, and Gold Standard are the three pharmacy specific databases we use.
What was the second one? I'm sorry.
First Data Bank.
Thank you.
Again, first time I've heard of that one, and Gold Standard.
Okay.
So I can't tell you much more than that, but those are the ones that we use on the pharmacy claims to edit. So I think that we've been able to use those because the way the language reads now, that crossed out number 2, National Specialty Society edits or any other appropriate nationally recognized edit standards. So we're concerned that when you're eliminating those, you're eliminating some of the other ones that we look to.
And if this covers drugs, would you be comfortable if we added those 3 and then keeping the NCCI?
Well, so that's my request on the drug piece.
Okay.
On the NCCI, I did ask our coders what would be eliminated. So if we're not using the National Society of Anesthesiologists codes, obstetrics codes, those type of codes. And then I did ask for a list, which I don't think I have yet, of all the specialty societies that we look to for guidance. Let's see. Again, like I said, I can't answer these questions on my own. I have to ask coding specialists every time. So she did send me, I'm not finding it quickly, so I'll have to send you an email, but she did send me some examples of things that we currently have coding rule edits for that are attributed to specialty societies. So I can be very specific and write them down and say what we would be losing by foregoing that. I have, and then I'll jump to the next page, D, the one that Jordan was talking about, that says no health plan contracting entity, covered entity, or payer shall subject any healthcare provider to prepayment review. I'd love it to say prepayment review of coding validation edits, just to be specific. And I know this is a different section of the statute, but prior authorization is a form of prepayment review that requires documentation.
So you wanted to say prepayment review of coding.
Validation edits. And then I agreed with the proposal that that MVP had that said broad application or something along those lines.
Okay.
And I can give you some examples. MVP gave you some examples of claims that we ask for prepayment review of. We do ask for it on high dollar value claims, so a very high value. We ask for it on bundled services often. I think it affects hospitals more, but when we're looking at the bundled payment and we want to make sure all the codes in that bundled payment are included together. So that's sometimes we validate those. We validate them if, let's see, if a member complains to us that they don't think that the bill they received accurately reflects, we ask for documentation of those. And then I think it's more covered under the auditing, but oftentimes after a provider has been through an audit, we apply prepayment review of the areas that were trouble areas or issue areas for a period of time to see if they've been corrected. And then we turn it off if we feel like it's working.
And are these areas that you're already doing this today? Hold on,
When you say we ask for, you ask for it from the provider. Is that what you mean?
Yes, we're asking for documentation,
From the provider.
medical documentation from the provider. Yes.
Not
We as
notification.
We as Blue Cross and Blue Shield of Vermont's, coding team.
And I want to be clear, you're not paying the claim, then you're asking for the documentation. Then you may or may not pay the claim.
Correct, or we may adjust the claim. I think that's likely what happens a lot of times, especially the super high dollar. I mean, I think we consider high dollar claim 100,000 and up, but we get claims for $1 million and more. So.
Sorry, and then Melissa.
My question can wait till you're done. I just wanted to get in the queue.
Okay. Go ahead, Melissa.
Can you give a little bit more example about bundled claims? Are we talking about high dollar bundle claims? I mean, because lots of things can get bundled.
Sure. So, I don't know if I have the example here. I don't see the example. You know, we bundle small things like colonoscopies, and then we bundle hip and knee surgeries in some places. We bundle obstetrics. So we pay a bundled payment for all the visits to I think a primary care practice or a gynecology practice for a patient who is pregnant. I can get a good example. That might not be a good one.
Some examples, that would be great.
I mean, I just want to make sure you're not like doing audits on like really low dollar lab tests, like liver panels are bundled, but because they're made up of like 3 or 4 different things. I mean, a cholesterol is actually technically a bundled.
Oh, okay. I see what you're saying. Lab is handled separately. You know, we have a lab vendor, and most of our approach to labs, and this came out of some really, really high cost lab work that we were seeing, is we've since created a network, and we ask providers to send the lab to a lab, the lab test to a provider in our network, a lab in our network, so that we can, you know, negotiate the price. So.
And then the prepayment review that you would like to maintain, will this be done in-house? Or is this going to be, are you going to have a contractor for it? I mean, you've always done prepayment review. Are we talking about people in Montpelier? Or are we talking about a third-party administrator?
So I think what this bill seeks to do is say that we couldn't do prepayment review, you know, on a broad swath. But I think I'm trying to think of, I think usually it's going to be done in-house, but I don't want to promise it's going to be done in-house when we do need to have, we don't have the capability to have the edit part in the house.
Okay. Do you want to ask your question, or you want Sarah to keep going?
Mine's back on the NCCI, page 5.
Okay, sure.
I don't know.
I'll try.
Okay. It's a question for you, but also I think something for us to think about as a committee as far as drafting language goes. Or it may not be. So sometimes we get into trouble when we're trying to, like if we leave, oh, we forgot this group, we forgot this group, we forgot this thing, and we start to list them out, and then we exclude entities that should be here. So wondering if there's a way to be less specific, but more specific enough, but less specific and more inclusive of other entities that might need to adhere to the edit standards, et cetera. Does that make sense?
Yeah, and I have to say, I don't know the answer to that because I don't even know what the companies do. Alyssa and Sarah.
Yeah, usually Jen's really good at answering this. I've worked, you know, on bills long enough that I know that the general rule is to not try and put everything in law because you can never get it perfectly. I think the balance we're trying to get here is you want, and the providers want assurance that we're not going to go outside the bounds that you're setting.
Right.
And so you're trying to put more in statute than you would typically.
Yeah.
Is what's happening?
Intense.
Right.
Maybe we could put a
Yeah,
check mark
we
on
could
that
put
for
a
Jen.
Yeah. Did you want to say something?
Well, I wanted to say something about that. I think the intent of the entire bill, to be honest with you, is consistency
Yeah.
and trying to align as many payers as possible to decrease administrative burden so you know what you're dealing with. Would you be amenable to, instead of listing, you know, various organizations, would you be amenable to something more along the lines of that your claim edits cannot be more restrictive or onerous than either CMS or in our case, Department of Vermont Health Access. That you can't arbitrarily, because you're right, there are a million different organizations that have, coding standards for all sorts of things. And I'm just wondering if there's a way that we can better align with, again, CMS. And is that something that you could be amenable to?
I think we should be, yeah. I think simplifying makes a lot of sense. I guess I have two responses. One is I'm hopeful that the work group you have later on in the bill, we can come to some consensus and try and, if we say, hey, we really need to look to this one, and they say, okay, that makes sense, that we could work through some issues like that in advance. And then the other thing that I have a lot of thoughts. I did find the one on assistant surgeon edits, if it helps to have an example of one of these exactly. So it's based on the American College of Surgeons. And these edits and recommendations are for reimbursement for assistant surgeons based on a review of relevant information. So what we've seen, and I've seen bills that do this, is sometimes they have a assistant surgeon and a regular surgeon both on the same surgery and get billed twice for two people in the room doing some of the exact same things. And so that's what those codes deny on.
Are you saying that if you have two surgeons, you only want to pay one?
For certain parts, there's two people in the room, so we have to pay for two people in the room, but there are certain things that they could be billing twice for, that we would only want to pay once for, because it's not happening twice, even though there's two people in the room.
Only one of them removed the gallbladder.
Or whatever it is. I'm not very good at giving the example, but.
But you needed the second person to hold your characters.
All right, I think we're gonna skip this example.
Sorry, I was reading what she wrote, and sometimes it makes sense and sometimes it doesn't.
I think the question stands though to both Jordan and Blue Cross Blue Shield. Can we say something cannot be more onerous than CMS and DVA? And so just think about that.
Okay, yep, happy to think about it.
Okay, you can keep going.
I did have one question on the last bit of the bill, now that we talked about the work group that apparently has been in statute and
Never done.
a meeting recently. It's page 9M. See, and again, this is where it says Blue Cross and Blue Shield of Vermont, and Jen is crossing that out and says there is a work group.
Yeah.
Happy to do that. I think that's a great idea. When I look at the very bottom line, it says the work group is requested to provide an annual progress report to House Healthcare and Senate Committee on Health and Welfare. It's not underlined, so that's already current law.
Oh, okay, right.
Clearly has not happened. Happy to provide you with updates from this work group. I think everyone agreed. Not sure if we want a report required in law every year, or if you just say, maybe we come back next year for sure, and then in response to any questions or something. But I'll leave that up to you.
Okay,
I'm not seeing where we are.
so we're on page 9, row 17.
Okay.
So it's currently in law,
Yes,
But it's
not
not
underlined.
not happening.
And that's supposed to be underlined?
No.
It's not, because it's currently in law. So
Yeah.
they're just saying, hey, this isn't happening today. Can we change it to something like, once we meet, provide an update or something like that? That
Crazy history. When I worked for the Joint Fiscal Office, I worked on a report called the Report on Reports. Great one.
Yeah.
Scintillating, truly. And I worked with someone who was in the administration, and we listed every single report like this that was required in statute and not being actually published, or being published and not really being used.
That is still happening.
Yeah.
Just had a group that went through that for us and actually got rid of some. which
We got
is-
coverage on the national news for that one.
Oh, really? That's funny.
Was it 2018? What was the last year that you did it?
Oh, gosh, I don't remember. I don't remember.
But I'm looking for the.
And the person I wrote the report with is no longer here, but he was fabulous, so.
All right, so is that the last?
Think that is.
Okay. I do want to give, I don't want to spend a lot of time on the list of questions. Sarah explained it to me that she went to others to get the answers, who know the answers to the question, which makes perfect sense. So, but if there's some broad statements or comments or, anything, I want to give people the opportunity to. And Lisa is raising her hands first, but is there anyone else that wants to go first? Mari, and then
I'm
Alyssa.
gonna appreciate your forthrightness and apology and listening to us, and it's very much appreciated.
That's all what I wanted to say. Well, I wanted to say, but I did want to ask a question. First of all, I am really grateful, and I think of anybody in the provider community who is listening to hear you say, that you acknowledge. I think that means a lot, because it has been a nightmare. But I also wondered, are you turning those edits off?
So,
How are you correcting?
great question. I think what we are doing, to point to the memo, is the sort of process improvements that you asked about to try and improve that. I don't think the plan is to turn them off totally, but we're also entering a new year and we've turned them off in a lot it's not being applied broadly like it was in the beginning.
So are you still hearing complaints from providers? And if you are, how you, so for instance, we heard, 2-hour wait. I think that was the prior auth, but we also heard it in this, 2-hour wait to have a discussion, education, how are you handling all of that?
Yeah, so the wait times are still not good in our call center. And we just don't have the people to answer all those calls. And I think the calls all go through customer service, and then some calls go directly to provider consultants. So I think the hope is to move more calls directly to the provider consultants when they're available, recognizing that providers have a whole different set of concerns. Losing my train of thought here. There were things that were done that were absolutely wrong, like having an email that didn't work is crazy. And then I do know that we've gone out to some practices, and we're open to going out to more practices who continue to have problems with the edits. I think we've turned them off in a lot of cases, but I can't say that we've blanket turned them off.
So do you have a written policy now for these specific edits that people have access to?
There is a modifier 25 and a modifier 59 policy on the website. In addition to a claims edit policy, which is more general about claims edits.
And I'm sorry, go ahead. And then Leslie.
I guess I'm going to make a statement here, and I'm going to make this a statement as a former provider. I really wish you would look at, I know that 25 and 59 have gotten a huge amount of attention, but the invalid primary diagnosis code, which is not an invalid code, nor is it oftentimes the primary diagnosis code, with no guidance on what code you're pointing to out of 12 codes. That is a huge problem. And I wish you would reconsider that, and your laterality modifiers on things that really do not require laterality modifiers, particularly when you require ICD-10 codes that already have the laterality on it. I wish that you would rethink those edits. I'm not quite sure what value Blue Cross Blue Shield is actually receiving by having these administrative edits in place. It just doesn't seem, I don't think you're gaining anything from it. And it's an administrative nightmare.
Okay. I will definitely bring.
I'm going to put that out there.
It's a lot of router to whatever that
Laterality.
Right or left?
What?
Which side
Right
of
or
your
left?
body?
Oh,
Side.
another body.
Leslie?
Yeah, I just wanted to echo, the thanks for the apology, but I think apologizing to us and the people that happen to be on the screen feels a little insufficient to me, in that there are many people out there who may not have known that you recognize the problems, that you are addressing them, and how you're doing that. So I'm kind of wondering how you're reaching out to practices who don't have the luck of being, in our field. So that's what I'm hoping that you can,
Sure.
and not just put something on your website, because that's easy.
I know people don't have time to read that.
No one's looking at that. So yeah, how does one, in a way, just make amends?
Yeah, and I don't know if this makes amends totally, but I think we did learn by having both the meeting, which was a smaller group of providers, but then when we had the webinar on modifier 25 and 59, I'll be honest, we had people internally, he said, nobody's going to come to that. They don't, I was like, oh, I think you're wrong. And we had a huge turnout of people. And I do believe the providers care. They want to do the right thing. They want to code properly, and they need to know how to do it. And I do think that the payer has a role in supporting them in that. I really, really believe that. And that's going to be, I think, one of the biggest changes you'll see at Blue Cross and Blue Shield of Vermont. I really do. I think that we've been very behind the times in our treatment of providers and supporting them in doing these things.
That's nice to hear.
It is,
It's going to start small. I'm trying really hard. So, yeah.
Art?
I mean, we're talking on a subject matter that I really know very little about, and I'm kind of listening here, but I'm wondering, will passage of this bill correct some of the problems with all this COVID?
I think it will. I think it will prevent us from doing us and other payers as well, doing blanket coding changes that require a lot of documentation and, administrative work to work through.
This will help that whole thing.
Mhm.
All right.
Thank you.
All right, any other questions for Blue Cross Blue Shield?
I just really appreciate the statement that you just made about providers wanting to code correctly, because that was a sentence that happened a while ago that was said in the opposite. And it was just like, it's not what we were hearing or feeling or experiencing. So I really appreciate that statement.
Great. Okay, thanks, Sarah.
Thank you, sir.
All right, so that was faster than I thought. So why don't we take 5-minute break, 10-minute break, and then I want to come back and have a committee discussion on 766. We still have one section to go through, the step therapy, but I want to try to start getting some ideas and thoughts of how we move forward on what we have on it. So let's come